Should we go, Dr. Partha?
Yeah,
With your
sure.
permission, I'll proceed. So, our first talk, we have 8 minutes for each talk, and we'll try to keep them into 8 minutes so that we have some time for discussion as well. And our first talk is really interesting, which is on flap complications management by Dr. David Smarja, and he's of course an authority, so we would love to hear it from you.
Thank you very much. Thanks again. Very happy to introduce this session. I'm going to start to speak fast because I received in my email 10 minutes. I kind of succeeded in dealing an extra minute from Eudacia. So I'm going to speak as fast as I can. Again, thanks a lot. And let's start talking about the LASIK flap complication management. I'm David Smadja, coming from Tel Aviv, Israel. And before we start, so that's my financial disclosure. Nothing here is will be relevant for this talk. Now, every time we speak about complication, I think it's very important to keep in mind a few things. But being an accomplished surgeon is quite similar to lessons that have been taught by life. It's not about not having complication, but it's rather how would you manage to successfully get out from them in an unexpected situation. Complication will occur, that's for sure. We all know that, and we have to be prepared for them. So let's see how we can get our LASIK right, and we have 3 different steps to go over. Number 1 is what we call docking-related issue. If someone stand by the laser and start to see the docking procedure, it's about 30 seconds, very smooth, 99.9% of the case. Everything goes so fast, you don't even know what happened. But it's a lot of different steps that happen. And sometimes the going get tough. So when we are talking about the going get tough, we're talking about, challenging docking that might occur. We're talking about here we go. We are talking about a loss of suction, a partial flappation, and sometimes the centered flap. And everything can happen with those 30 seconds. So you have to keep calm and just to know what to do next. And first, you have to do how to make things right and make things right at the first time. So 3 tips to make sure your docking will be a good one. Number 1, pay attention a lot to head positioning. Look at this patient, has everything, every risk factor for having a bad docking. He has small eyes, sunken eyes, prominent nose, prominent orbital ridge. So you have here to pay attention to different things. Number 1 is the head positioning. You have to, always pay attention to tilt the head a little bit to clear the path for the docking position. Number 2 is to center the eye. And we have different signs for that. You can see here, for instance, that this patient is particularly badly positioned. You can see that we do not see any meniscus of conjunctiva at the bottom part, and therefore he has a reflex that is not centered. So that's the nice picture you guys have to see before you start pressing on the pedal. You have 2 nice meniscus of conjunctiva, and you have a very nice reflex here. So that's the green light to move forward. The second thing is how to nicely dock your patient. Number 1, you have to remember that the pupil is always positioned nasally. It's not at the center of the cornea. So you have to plait the suction ring adjacent to the temporal limbus. And then you look at the green, you look at the light reflex, and you can get the smooth and perfect centration. Look at this video. I just put the ring very close to the temporal limbus. I have this nice meniscus nasally. And when I start to dock, I will touch the cornea right at the center of the pupil. So that's what we are looking for. Now, the third thing is always to pay attention to squashing as much as you can the conjunctiva. Look, this horrible video, you start to make the docking, the conjunctiva wants to come over. That's the horrible scenario. So this is the second eye of that same patient. My fellow is working. I'm telling him just to pay attention a lot here. You can see this meniscus that is very close to getting into the position. You have to play a little bit more with the rings to make sure things will stay at the same place, and then you can have a smooth flap creation. Now, even though you did everything, sometimes they're going to get tough anyway, and it's not anymore about what is happening, but how to handle the situation. So let's go back to this patient. We have 2 types of things. In this patient, we have a loss of suction, but we have already partial flap that have been catted. So when the flap has been catted, you can see the end of the procedure. He keep pressing on the pedal, and then that's the final picture. When you look at this, you can see that we have barely 95% of the raster being cut. We have probably about 70% of the side cuts. And one of the nice techniques to activate for rescue at this point is what we call flaporexis technique. You can see here in this patient, you start to work in any place you can. You see, we have here the side cut being cutted. You dissect everywhere you can dissect. I have here this nice 95%, and that will be enough. And at this point, you take a forceps and you just follow the line. You know, the line is not completely cutted, but with the help of the forceps, it will help just to follow the light and to complete the procedure and to expose the stroma a very nice way. So the procedure, you know, was like an uneventful procedure with this, the help of this technique. Now, sometimes you have loss of suction that is more extreme, and you cannot complete any procedure anymore, like you can see here. So we published 10 years ago now, kind of decision tree management for that type of situation. And you have 3 types of situation. Number one, you lose the suction during the lamellar cut, and it spares the center. So you can repeat the same procedure with the same parameters, same material, same applanation call. Try to make that as fast as possible to make sure the conjunctiva doesn't swell too much, and things will be fine. You can have another scenario where you lose the suction, but at the center. And in this case, you should avoid doing that again, because you will have these stromal steps that might occur exactly at the center, and that will increase the risk for irregular interface, and that will affect the patient vision. So we just have to convert, wait a few weeks, and then convert to PRK procedure. And then we have the last scenario, which is probably the most simple one. It's when it happened during the side cut. Just have to repeat the procedure with the same applanation cone. If you guys have a laser with side cut optionally, then pick that one, and you reduce the flap diameter by about 0.3 to 0.5 millimeter. Now, the second type of complication is intraoperative related issue. And one of the things we might see, especially in a contact lens wearer, is bleeding. And bleeding most of the time is related to the fact that the side cut was too close from the limbus and cut some of the vessels there. So you can see flap is dissected normally, and at some point you start to see a lot of bleeding here. It starts to be almost like an orthopedic surgery. First time we can see that. That's very nice. We can say that we're a real surgeon now. And you can see this bleeding, but at this point you have to remember clear steps to move forward. Number one, you have to clean everything just to make sure you have your iris recognition. As soon as you have that, then you have to dry the stroma to make sure you can have a nice ablation with no undercorrection. And then you can use phenylephrine, for instance, in order to constrict a little bit the vessel and control the bleeding for the flap repositioning steps of the surgery. Now, another type of intraoperative issue might be stromal ablation mismatch. Look at this patient, for instance. This patient has a very bad irregular astigmatism of nearly 3 diopters. And the reason for that is because the flap hinge has been hit by the laser. So at this point for this patient, only PTK or topographic guided ablation can come to rescue in order to restore the optics of the cornea. And if you see from this side, then you can understand clearly why, if you do not protect the hinge, how many pulses in a hyperopic patient or patient with a Gander rule type of ablation that will be vertically might strike the hinge. So you have to protect the hinge with a spun. Sometimes some laser allow you to customize your flap, as you can see here. And then, for instance, when you have again the rule astigmatism, the ablation profile will be vertically. So you can just rotate your flap, making sure you clear the pass, you protect the hinge, and then you will see that the hinge position will also not be overlapping the stromal ablation pattern. Now, the last type of complication is the postoperative surgical related issue. And the most feared one is probably late microstria or macrofold. And there is just one rule, very important one. Anytime you have microstria that is symptomatic, you have to treat that as early as possible, because otherwise will start to be filled by epithelial cells and it will be very difficult to manipulate this here. So look at this microstria. The patient came to me after 10 days. and I had to remove and scrap the epithelium to start to manipulate. You can see that the flap is completely shrinked close to the hedge, and I have to use now irrigation with hypotonic solution in order to swell a little bit the flap, and then to apply gentle pressure in the opposite direction in order to restore the flap and put that back into position. So the rule here, if it's symptomatic and if it happened right after the surgery, you have, guys, to treat that right away. Otherwise, you will have to get into a more difficult position with removing the epithelium. Now, one of the nice technique I find for addressing this is the golden ring technique that I call. You can see here the nice golden ring. And the idea here is really, when you put back the flap into position, you don't want the flap being sliding on a bubble of water. You want to wash everything, but then you have to do a small massage. And one of the nice signs to make sure everything is out and the flap got, locked back into position is this nice, as we have in golden ring and cataract, to have this nice golden ring for the flap edge position. That ensure you that your flap has been being back locked into position. So remember, when you are in the operation room, you could be either that type of guys, that have complication but cannot manage, or you can be that one that have also complication but is skilled enough to control the situation. So thank you very much for your attention, and we'll be happy to answer any question.